Good evening, everyone, and welcome to Elevate, a GE Healthcare webinar series. My name is Dr. Arlene C. Riodica, and I am the Clinical Education and Applications Manager for Life Care Solutions, GE Healthcare ASEAN, and I will be your moderator this evening. Some housekeeping tips before we begin. First, all participant microphones will be kept on mute so there is no feedback during the webinar. You may type in your questions for our speaker at any point during the webinar in the Q&A window you will see on your screen. But these questions will only be addressed once the presentation is done. After the Q&A, please kindly help to fill up the poll questions that you will see on the poll window. During this time, you can also already register for our next webinar session by clicking on the link shown on the web link window. Our next webinar session will be on implementing standardized response to deterioration using the National Early Warning Score, to be held on October 5, 2020 at 6 p.m. Singapore time. Tonight, we are privileged to have a distinguished speaker with an extensive clinical experience. Our speaker obtained his medical degree and graduated cum laude at La Universidad Complutense de Madrid, which is one of the oldest universities of the world. He then went on to serve as an associate professor in anesthesia and critical care in the same university. He is a professor in anesthesia and critical care in the Universidad Autónoma de Madrid. In between his academic and clinical responsibilities, he finished his MBA in Healthcare Administration and Hospital Management at Universidad Complutense de Madrid. He worked at the Hospital Universitario La Paz Madrid as a specialist pediatric anesthesia and critical care for 5 years, and at present is on his 9th year as the chair of the Department of Anesthesia in Hospital Universitario Puerta de Hierro, Majadahonda in Madrid. As a researcher, he has over 100 abstracts and research papers to his name. Many of these are human and animal studies on pharmacokinetics of anesthetic drugs, ventilation, and pediatric ventilation. He is also an associate editor of the Ibero-American Journal of Non-Invasive Ventilation, Current Anesthesiology and Resuscitation, and Revista Española de Anestesiología y Reanimación, and the president of the Research and Ethics Committee of Puerta de Hierro Hospital in Madrid. Let us all welcome Professor Javier Garcia Fernandez to give a lecture on lung protective ventilation in the operating room. Over to you, Professor Garcia.
The audio because it was muted. I hope now you can hear me now. Okay, thank you so much for this nice introduction and for inviting me to have the opportunity to talk about my passion. Really, I started 18 years ago in training mechanical ventilation. From the very beginning, I have to only to say a few words about my background, just to understand my view, my personal view about mechanical ventilation. I start as pediatric anesthesiologist in one of the biggest monographic pediatric hospital here in Madrid. And then I moved position to intensive care, but in the side of pediatrics. So I have these two backgrounds in my back. And after 10 years ago, I decided to move position as a chairman of the department through a national exam. One of the biggest well-known hospital here in Madrid for research and only for adults mainly. So now I have to move to anesthesia and intensive care in adults because we run all the intensive care beds there of the surgical patients and transplant programs. So due to all these different background in different areas, always focusing in mechanical ventilation, you will see that my point of view in some cases could be quite different of other key leaders' opinion. But this because I learn a lot through the physiology of the neonates and small children. I like both sides, clinical side and research in the lab, and it's because in some cases you need to, if you really to answer very important question, it's really impossible to do it with human beings, but only with the most respect about that. Really, I feel very lucky because I mean, I totally feel free about what I'm going to talk today and all the ideas I want to spread. The first thing we want to share with all of you is mechanical ventilation. We know is not easy. I mean, you will see that we try to do as most visual and simple possible, but definitely there are a lot of lung physiology behind. That lung physiology is not a common sense subject. I mean, you have to study and to know the rules, and sometimes it's not it's not really common sense pure concept. You have to study, and if you don't master lung physiology, then if you go directly for the papers and randomized clinical trials in mechanical ventilation, is quite tricky and quite complicated. And I'll give you quite a lot of examples of that. So really, we are going, in this first lecture, we are going to talk about two approaches and a different point of view and a different way to really master mechanical ventilation. My approach is like, if you master lung physiology and if you master a few concepts about mechanics of respiratory systems, then you can answer most of the important questions that now through the clinical trials is really difficult, because there are a lot of confusing data. And the second part, we are going to master how do we breathe, because the concept is simple. Now, to master how to protect the lungs against mechanical ventilation is more important than ever. With the COVID pandemic that is destroying a lot of lungs all over the world, we are going to see many patients that after passing COVID infection, they have to go for OR surgeries, and they have to go through operating room procedures, and we have to treat them, these lungs, very gently, because these lungs already have passed through the heat of this virus. So the concept is clear. If we master how do we breathe, and we try to copy, we try to emulate, we try to do as more similar possible as the physiology way, I can tell you any clinical randomized trial can say a single word against this simple and clear concept. So we are going to go for PEEP. You know, this is I did this research the last week. You can do it. If you go for PubMed and you type PEEP and mechanical ventilation, just to avoid all other concepts about PEEP in other areas, you can see this data. PEEP started around 1915, and the beginning few studies around there. But imagine after more than 50 years ago, we have PEEP in our ventilators, and still people are totally sure about how to set it. And why? Because through clinical randomized trials and through papers, we don't have a final clear idea how to do it. And it's one of the most important, powerful tools to protect the lungs. And imagine, even in the last 5 years, you see in 2013, there was 1,300 papers just to try to find out how to set PEEP. So see the problem. I shared this slide. It comes from Professor Paolo Pelosi, that I love him. He's a very nice guy, but my approach is totally different that Professor Paolo Pelosi about protective ventilation. And he shows this slide that I asked him to give it to me. Say, I'm going to say just the opposite that you usually said. And you say, oh, okay, Javier, no problem. You know, finally he's giving this kind of messages, a really strange message, like the funeral of PEEP. PEEP was a dream for generation of anesthesiologists. So I'm very sorry. My approach, if you come from pulmonary physiology, if PEEP is dead, mechanical ventilation is totally dead. It doesn't work for anything. It's really, this is the real situation and the crude situation about PEEP. And you know why you can have this kind of strange message? Because if you go through randomized clinical trials with any common sense and physiology approach before, the results can be totally strange. And the first thing, most of the papers about PEEP is talking about the amount, as we are going to find out the magic PEEP for all the patients all around the world. Come on, please think about your physiology, because physiology is inside of your brain. What is high PEEP or low PEEP for you? You know, that is what makes me special for me. Please get one pediatric anesthesiologist, get one neonatologist, get one clinician from intensive care in adults, and get, especially from the open approach, and get one anesthesiology for adults. If you make this the same question to all these 4 people, what is going to be the answer? I can tell you, for neonatologists or pediatric anesthesiologists, no, people 5 is too much. I'm going to break the lungs of the patient. And if you ask for the intensive care unit for adults, especially if you come from the open approach from Amato, they're going to say, high PEEP, Javier? High PEEP is when you use more than 15, 5, or 20. So, you know, this approach, every time you see a paper about high PEEP or low PEEP, I'm very sorry, this is not the right question. So please don't waste your time reading this paper. Second, you can find hundreds of papers trying to find out the magic PEEP for all patients in abdominal surgery. You are going to see papers doing with lung physiology approach, and show you that this is one of the most nonsense, let's say nonsense question at all. Do you really think that all our lungs are the same? Do you really think that the functional residual capacity under anesthesia is going to be changed or altered the same for all patients? Come on. If our lungs are different, that is clear by physiology rules, it cannot be treated the same. So is there a magic pill for all same surgical procedures? No sense at all. Even I want you to make you think, because this last question is quite strong, and it can be perfectly answered very easily and with any kind of doubt if you master lung physiology. If I ask you, does everyone need the same amount of PEEP for this to obtain the same saturation of PO2? What is the real answer? The answer is no. So can you tell me one single reason why PEEP still now is programming due to the concept of PEEP table from ARDSnet, that they give you some amount of PEEP to obtain some amount of PO2? And we know that this is totally untruth. It depends on the situation of the patient. So, you know, now you have a lot of answers to understand why PEEP is so confusing term. So why don't we ask physiology? Because it's very simple. Really, this is not very complicated. The first question about PEEP is to master what does PEEP do and what doesn't. So this is a video that showed to us, I think it's going to start now. Okay, here it comes. This video is crucial. I highly recommend that you see this video. I have hundreds of this, you have in YouTube. Isolated lung is crucial to understand how the lungs works. You can see now that without PEEP, you have collapse during expiration. When you set PEEP, that is CPAP or PEEP, the lungs stop recollapse during expiration. But the pressure who reopen the lungs is not PEEP, never ever, is the maximum transpulmonary pressure during inspiratory time. That is when you give the high pressure. So no PEEP like now, you have collapse, and you have collapse in every single breath. And you say, oh, Javier, but saturation is perfect. Yeah, of course, because saturation correlates with the maximum surface during expiration. If the lungs go for collapse, it doesn't matter. So no PEEP, you have collapse during expiration. If you set some amount of PEEP, is only to keep the lungs open. So please, every time from now on that you read a paper saying that set a PEEP of 5 or 10, it doesn't matter, and you will recruit the lungs of the patient, it means yes or yes or yes, that I'm very sorry, these authors don't make the effort to master pulmonary physiology. And if they don't know pulmonary physiology, it's better not to keep reading their papers because the data is going to be totally confused. So throw this paper away and go for the ones who really make the effort to really understand how the lungs works. So we are going to continue now for the next slide. Thank you. So the first concept that we have fixed is PEEP never ever recruit the lungs of the patient. The way to recruit the lungs of the patient is through recruitment maneuvers. And then we use the PEEP to keep the lungs open. So the first thing that you don't need any clinical randomized trial to know is that you have first to open the lungs and then set the PEEP, the minimum amount of PEEP to keep the lungs open. And this cannot be discussed by randomized clinical trials. This must be mastered to study, hard study, and master pulmonary physiology. This is another research that I did a long time ago because when I was a pediatric anesthesiologist, I've been taught for many professors, say, PEEP, Javier, don't use never PEEP more than PEEP of 5 because you are going to create pneumothorax to neonates. Okay, so I did the research. I've been studying for the last 50. The guy who have broken more lungs is myself in my lab, obviously with animals. So I'm mastered the process of pneumothorax. This is one of our research doing in purpose to answer this question. What we did here was with real neonate newborns or less of 48 hours, obviously pigglets. We break all the lungs of these animals, and what we did it in two different ways. One of them with very high PEEP. In this machine, I can even reach a PEEP of 50 of PEEP and a constant driving pressure. And in the other group, we keep the PEEP to 20, and then we only increase driving pressure until we break in all animals the lungs. And as you can see here, PEEP, high PEEP, is not a dangerous factor. It's not a risk factor for pneumothorax. Just the opposite that we've been taught orally mainly, because there are not many papers in this way. But totally wrong. It's a fake concept. PEEP is a protective factor. We all know that between the three pressure we have, the most risk one, obviously, nobody have any doubt of this, is the maximum transpulmonary pressure. So the plateau pressure, the higher the plateau pressure, the higher risk you have. But the second pressure is for risk of pneumothorax is not PEEP. I'm very sorry. So if someone have told you that, please erase it and start again. PEEP is a protect factor. The second bad pressure to create barotrauma is driving pressure. If you use high driving pressure, you break the lung sooner than if you use low driving pressure. This is another concept that is totally spread all around the world. I'm very sorry, but this is the cruel reality. And this comes from the famous PEEP table, the PEEP table from AirDesNet group. They tell us like, okay, the patient is desaturated, the only thing you have to do, increase the PEEP in a step of 2 to obtain the oxygenation level you want. Totally wrong. This is a patient, a real patient from Amato unit, and as you can see here, the same patient is a severe distress syndrome. Before and after a recruitment maneuver, the same amount of PEEP, in this case, it was 21 of PEEP. Imagine, 21, for the one who said, no, high PEEP is 5. 21, obviously, in an extremely severe distress syndrome, nearly to die. So before a recruitment maneuver, they improve compliance. So if you improve compliance with the same PEEP, this means like the driving pressure is going to be much lower. So the same patient, the same amount of PEEP, setting this PEEP after or before a recruitment maneuver, things change totally inside of the lungs. So, to sum up, I know that there's a lot of new concept. I'm probably against what you've been taught. I'm very sorry about that, you know, but this is the crude reality of mechanical ventilation. Now you understand how through papers it's very difficult to really find out the real concept. What we can say about PEEP is like PEEP must be set individually. How can I do that? In different ways. The most common way for any clinician all over the world is best lung mechanics and the best elastic point, so the highest dynamic compliance. Why? Because all over the world, no matter the machine you have, you always have dynamic compliance. And if you have it, you have to calculate it. And besides, you have to change the machine. Sunday, we have to change anesthesia machine. You know, I don't know why. In intensive care, they have the best machines with the latest software where everything is perfect, and they change it every 5-10 years. And in anesthesia, still in some areas, uses the same machine for the last 15 years. No? So even if you don't have the number of highest dynamic compliance, you have tidal volume, and then you have driving pressure. That is maximum pressure minus PEEP. So the formula is very simple. Tidal volume up, tidal volume divided by driving pressure, then you have dynamic compliance. The second point, if you have saturation, everybody has saturation, so you can use SAFI, saturation divided by VO2. In the range between 90 and 97, there is a linear correlation between SAFI and PAFI, and it's almost the same, 20 points more or 20 points less. I learned this through my pediatric side. In children, you cannot get arterial lines so easy, and it's with a lot of problems. So we have to manage the patient with saturation. So go for that. Really, probably today we don't have that much time for that. This can be we can talk about in another webinar. So the other thing is, if you have arterial gas analyzer, you can use PCO2. The difference between PCO2 and end-tidal CO2 that we all have in the OR is a very general measure for dead space. So the less dead space is the best PEEP. And now I highly recommend to see it. You know why? Not because you are going to do it routinely, because it takes more time. It's because to convince you about all this new concept I'm talking to you today. If you put ultrasounds and lung ultrasound and you see all this concept works perfectly, from now on, you are going to use it. And obviously, the other very nice visual tool is electron impedance tomography. And in the future, probably we are going to guide PEEP through cardiovascular effect. Okay, to show you that there are clinical randomized trials doing for good guys who really have this physiological approach and things make sense. So it's not only physiology, it's physiology plus clinical randomized trials doing for the guys who really master lung physiology. I highly recommend to read this paper. This paper is something very nice. They have a tool. They have a belt, the electron impedance tomography. So they put a belt in abdominal surgery in the thorax of the patient. So you can see like a CT scan, but it's a free radiation device, how the lungs behave during abdominal surgery. The first concept, this graphic tell us, this figure is incredible. For the ones who say, oh, Javier is saying strange things. Okay, for the ones who think that you can set the same PEEP, set the PEEP of 5 and everything is solved, here you have the answer. Here, the white dot is open surgery. All of these patients abdominal surgery, okay? So this open surgery, and this is laparoscopic surgery, the black dots. So, and this is body mass index. So for the same, let's go for example here, for the same amount of body mass index, so people obese and no obese patient. In this range, for example, his open surgery. Open surgery can go from 6 to 12. From 6 to 12. The same body mass index, the same type of surgery, the same everything. And every patient needs his PEEP. So here, for example, you can see mixes laparoscopic procedure. It changed from 12 up to 16. And how are you going to know if you don't try to individualize? So please, I'm very sorry. Everything what we have told is the pure truth. It's just physiology. Physiology never lies. This second part, I really love it. In this part, they show to you that two ways of doing it. Like is the typical PEEP of 5. In this case, they use 4, but it doesn't matter 4 than 5. So sorry that maybe I don't explain at the beginning. This paper, what they do is abdominal surgery, open and laparoscopic procedures, and then you set PEEP in 2 ways. The traditional PEEP, fixed PEEP of 5 for everybody, and individualized through this belt that you see when the lungs are open or are closed. So this is the 2 ways. So if you individualize PEEP, see the difference. You can reduce driving pressure up to, you see here, up to -10. So if you, instead to give a fixed PEEP, the driving pressure is going to be higher. And why higher? Because you overdistend the upper part. Instead to reopen the lungs and set the minimum amount of PEEP to keep those lungs fully opened, you can reduce driving pressure up to 10 points. Incredible. For the ones who still are not totally convinced, this final view is, I mean, there is no, you cannot say anything. What they did, this is the fixed PEEP of 4 without any recruit maneuver, with no individualized PEEP, and this is the recruit maneuvers plus individualize the PEEP. The first thing you can see is like after that, the collapse, if you don't recruit the lungs and you don't set individualize PEEP, collapse can reach up to 49. 49, almost half of the lungs. But instead of that, if you individualize PEEP and recruit the lungs, collapse is less than 1.4, 0.9. But in this case, they did a real CT scans in 48 hours later, in the post-operatory period. That are now in my country and in Europe is totally forbidden, but okay, it's good for us because we have the images. So they performed a CT scan. It was not after, it was in the first 24 hours. And as you can see here, the ones who don't receive recruit maneuvers and have a fixed PEEP of 4, the lung mass collapse can reach 26% after the surgery. And for the ones who goes for recruit maneuvers and individualized PEEP through this electroimpedance tomography, they don't have collapse. So it's not only physiology. If you go through physiology, clinical randomized trials give you the right answer. So as a sum up about PEEP, and we finish this part, PEEP has to be programmed individually. Yes or yes. The most common clinical way is through the highest dynamic compliance, lowest driving pressure. For this patient, in this right moment, and don't forget about rules. And every time some guy give you general rules, it means that they don't make the effort to really understand the process. PEEP only works to keep the lungs open. It never recruit the lungs. So PEEP itself never ever is going to reopen the lungs. PEEP has to be programmed always after a previous open lungs. That's why we are going to explain the second part. That is, this is the reason that we have to recruit the maneuver, to perform recruit maneuvers in order to know the PEEP that everybody needs. So let's go for how do we breathe, the second part. I like this paper from Talmor that compare the way, the pressure that we use during spontaneous breathing and the pressure that we do during mechanical ventilation in distress syndrome. The first thing we want to fix is like to move quite a large tidal volume. I mean, half liter, you can see here, half liter of tidal volume can be moved with around only 6 centimeters of water of driving pressure. So the concept is clear, and if you signed or suspire, that is very good for the lungs from time to time, especially if you see good things. So if you signed, you can even almost double the tidal volume, and the maximum driver you create is -8. So we use very low tidal volume to move quite a large tidal volumes. But under mechanical ventilation, we don't, this is the big problem. We don't pay attention on this. And you will see how still now we are using large tidal volume, even and large driving pressure, even more than 15 of driving pressure that now we know create a lot of damage. So I want to fix you these two videos, these two situations that I really is very important to understand how they works. In the left side, you have normal the way that the lungs works usually. And in the left side, we have the way that the lungs move under mechanical ventilation. In the left side, how they did it, this is a study from Professor Gary. It was in pigs, so they open a window. They open a window in the thorax, in the surface of the thorax, and they put a special microscope. So for the very first time, I remember, the first time I saw these images, wow, I was nearly like, oh my God, this is amazing. Because for the very first time, you can see directly the alveoli and the acinos. All this group of alveoli is called acinos. It's a group of alveoli. You know, during spontaneous breathing in the left side, this is the way you are breathing now. And as you can see, we are not designed to have a single atelectasis. This is another one concept. No, some guys during the night in the back part have atelectasis. I'm very sorry, no. If you have the atelectasis during several hours, then you have infection and problems. So if you don't have any respiratory problem, your lungs are perfectly well protected. All of them are fully opened during inspiration and during expiration, very important concept, and never go for collapse. Whenever you put a tube in a patient, this is controlled ventilation with a PEEP of 5, in the peak in this case, and in this case it was not enough. You see the problem. I want you to fix these images for the rest of your life, because this video really taught me a lot of things. For the ones who think like, no, Javier, but high PEEP create overdistension. Can you please see this situation? When you are not using enough PEEP to keep the lungs open, during expiration period, these two alveoli go for collapse. It's clear. Nobody can say a single word about this. I'm very sorry. No matter the randomized clinical trials you put in front of me. So whenever you allow some alveoli to go for collapse, what's happened with the ones who remains open all the time? They have to overdistend. It's just the opposite that we've been taught. As much atelectasis you allowed inside of the OR, you have instantaneously in the upper part more overdistension. So the story is, if you don't fully reopen the lungs, and then you don't set the minimum PEEP to keep all the alveoli open, yes or yes or yes, obviously the ones who go for collapse have to be reopened during inspiration. This is called atelec trauma. We all know that. Even the ones who don't go for recruitment maneuvers have to recognize that. But this second effect, very few guys in the world is teaching us. Every time you have atelectasis, you create cyclic overdistension. So the story, like all the lungs have problems. Okay, so let's continue now. And thank you so much you are doing a great job from the central control, really. And here the connection is perfect, so thank you for what you are doing. You know, it's not easy. It's not easy to create a webinar for the whole world, and that everything works so well. So up to now, we can say, please have clear that this is the way we ventilate spontaneously, and if we don't recruit the lungs and we don't set the PEEP, this is the way we've been a ventilator patient in the past. So what we can learn from physiology is, do we have atelectasis during expiration period? The answer is no. Does the size of the alveoli change between inspiration and expiration? Yes, but very little, very little. We are not designed to have large tidal volumes. Do we have heterogeneous distribution, the tidal volume? The answer is no. And nobody can say anything against this. Can we change tidal volumes? Adults, yes. And see, neonates, no. And it's a meaning, it's something that we can learn from them. So what we can say through physiology is lungs are designed to receive an homogeneous, no heterogeneous, homogeneous, well-distributed low tidal volume, and larval pressure is always must be less than 8. If you have an increase in oxygen demand, the physiological response is increased respiratory rate, but not with auto-PEEP, and just what neonates do. Okay, so now we know how to set PEEP. Now we know the way we breathe and the best way not to create damage. And now we are going to see how we can create damage through the ventilator. In anesthesia, inside the OR, on intensive care. Because this is another wrong concept about, no, Billy, ventilator-induced lung injury is for intensive care. This is not true. We know that this is the fourth classical mechanism, but I try to individualize, to put this concept for OR. The main concept in OR is like biotrauma, for example. In normal condition is not an important mechanism. Obviously, in polytrauma patient, extremely bleeding patient or patients or whatever, okay. But it's not in routine practice. But in our routine practice, inside of the OR, that's what we call is the most important way to create damage in the lungs is atelic trauma, as you have seen, because atelic trauma is correlated with cyclic tidal recruitment, and is the most important factor to create damage. About barotrauma, we don't have time. Maybe in another webinar we can amplify the concepts, but really I choose driving pressure as most important factor to control for two mainly reasons. First of all, because everybody can control all over the world, from Japan to States, from South Africa to Europe, everywhere have in front of him driving pressure. Mechanical power that now Atinone is trying to get in fashion is a very complicated formula that if you don't have the software at the machine, it's impossible for you to calculate. Second, the most important factor inside of mechanical power is driving pressure. So please, okay, let the big guys to argue about theoretical approaches, but I consider myself a clinician and I talk to clinicians. So really, for a clinician point of view, driving pressure by far is the most key point to control for barotrauma. And please remember, you have seen that. This is not tricky things. This is not clinical randomized trials. Whenever you have atelectasis, think about cyclic tidal recruitment, atelic trauma, but think about cyclic tidal overdistension in the upper part. Okay, so let's go for the final part. For me, that's my approach with recruitment maneuvers. When people say, Javier, we are expecting lecture only about recruitment maneuvers. I'm very sorry. If I don't talk about PEEP, it doesn't make sense to talk about recruitment maneuvers. If you are not going to use PEEP, don't use recruitment maneuvers. And if you are not going to use recruitment maneuver, don't use PEEP, because you are not going to see the final protect concept. So about recruitment maneuvers, there are many questions and a lot of papers, and once again, you don't have a clear message how to do it, and if it's good or it's bad. You will see why again as PEEP. For example, there are many clinical randomized trials. Every time you see a clinical randomized trial about recruitment maneuvers that start with pro, P-R-O, that it means no, in favor, it's tricky. It means against. So pro bis, pro for, pro bilo. It means, you know why? Because they don't make the effort to really understand what is a recruitment maneuver. For example, they advise to do it in volume control or pressure control. It doesn't matter. Oh my God. Oh my God. Oh my God. I mean, if someone say in front of you that recruit a lung and the volume control or pressure control is the same, I can tell you, they don't even know what is recruit maneuvers about. Because yes or yes, recruit maneuver, open the lungs, is a pressure and time maneuver. The only way, as far as I know, to control pressure is pressure control. See, simple things that for me it's incredible. So should we set fixed PEEP for everybody? If you don't individualize, you're not going to see any benefit from recruit maneuver. That's why I always talk about the same things, because it's like two hands. If you don't put both at the same time, you're not going to get the good side. So I already have sent this paper to Yi, and because it's an open, this is an open paper. This is what in 2018 the most downloaded paper from our journal. It's in English, and I dedicate I sum up in 1 year all what I've been studying in research and clinical side about recruit maneuvers in anesthesia. So we are not going to have enough time to talk about all of this concept. So please, I highly recommend you to go through this paper. But we are going just to talk about the most important points. For example, as far as I know, very few papers have talked about all the implications and all the damage that you can create in volume control if you go for recruit maneuvers. Okay, so this is an CT scan. It's a three-dimensional CT scan of a healthy rabbit of 3 kilos that you see before the induction of anesthesia. We are not designed to have atelectasis. This is the negative, this is air, so it's the negative size of the lungs. And as you can see, this is the diaphragm size. There is no any single atelectasis in the back part, and this is the front side. Just after induction of anesthesia, in only 2 minutes, you have this huge amount of atelectasis. And this happens every time the situation is not balanced. Why do and when do we have atelectasis? We have atelectasis every time there is not a balance between functional residual capacity and closive volume. So whenever the closive volume is going up or the functional residual capacity is going down, atelectasis appears, and it appears instantaneously. It's not magic. No, only 1 hour after anesthesia, whatever. Every time you hear this kind of message, please hear from them other things, but not about recruit maneuvers and PEEP. So the only way to keep the lungs open is to increase functional residual capacity. What is the major respiratory effect of general anesthesia? All papers, all physiology papers, reduction in functional residual capacity. That's why we go for collapse up to 90% of the patient, depends of the age and the situation of the lungs, after induction of anesthesia. And the only way to stabilize that is to reopen the lungs and to apply some amount of PEEP to keep the lungs open. I highly recommend to say, oh, Javier, probably you are the only one who speaks good about recruit maneuvers. No, go for this meta-analysis. I love it. It's wonderful. That, get all the studies, more than 440 studies, and see the conclusion of this paper, nothing to do with me, other part of the world, and see the conclusion of all these authors. Are there recruit maneuvers follow a PEEP? Follow a PEEP. So the ones who talk about recruit maneuvers without talking about individualized PEEP, stop reading it, don't waste time. So should be instituted after induction of general anesthesia. Recruit maneuver allow anesthesia providers to reduce VO2. You will see that all these hypoxemic events don't happen to you anymore. And see this part that we didn't have time now, but now there are a lot of research and clinical trials telling you that even if you go for this open approach, you reduce postoperatory pulmonary complications. So how can we do recruit maneuvers? And what are the ways not to do it? As important is to know how to do it, como how not to do it. So we started with CPAP maneuver. That was the first one. With Amato was one of the leaders to start with this approach, telling us like CPAP of 40-40, because I always ask him why you would choose 40-40, Javier, because it's easy to remember it. Obviously, all this maneuver works. Reopen the lungs. What is the story? That now we have a lot of information for research side, that you have more hemodynamic repercussion and more destruction, let's say more damage, microscopically, in the lungs. So now we don't recommend it anymore. Obviously, sorry, the first we have to stop. This is bagging. Bagging the patient. You know, it's incredible for me. That's why I hardly please read the paper, because here you have a whole approach of the concept. You know, one thing that for me is incredible? What do you do every time a patient inside of OR desaturate? Get the bag and no? This is a few cycle high pressure recruit maneuver. The story is like, now we know that this is the best way to damage the lungs. And then you have risk for pneumothorax, you create damage, inflammatory damage, and it's much worse for the lungs. Why? Because you open with very high peak pressure and then you go for 0. 50, 60, 70. When you bag in a patient, there are studies showing to us that if you don't have a special valve to control the maximum pressure, you can reach even more than 100 of centimeters of water. So please, instead to bag in the patient, recruit the lungs with a safety maneuver. So the only way we recommend, and the ones who taught me to do it, was neonates. The neonates is a very sensitive model for hemodynamics and for pneumothorax, told us that, and now even the adults, Amato, everybody, Marini, everybody recommends to go for pressure controlled ventilation with a constant driving pressure and a stepwise maneuver to increase PEEP in step of 5. This is the paper showing to us like CPAP that is good to recruit the lungs, but you create more damage. You can see here like the first thing important to tell you, no recruit the lungs is a bad decision. This is normal lung. It's not needed to be a master in anatomopathology finding. This is normal lung. Everybody can recognize. Not doing anything, do nothing. It hurts. It hurts the lungs. So here you can see that no recruit maneuvers create damage for all the concepts I told you before. Overdose tension and atelic trauma. If you go for recruit maneuver with sustained insufflation is CPAP, you create this small damage that obviously is going to recover, but is there. If you go for constant driving pressure, is the more similar to a normal lung. So that's why we move to recommend this way. How can we recruit the lungs? Or what is the best way to recruit the lungs? We go, first of all, pressure control ventilation. We set a driving pressure of 15, so 0 PEEP, 15 of maximum pressure. Be careful, because all new machines, all of them, when you set directly driving pressure, so the machine is going to keep it constant. In the old ones, change it, but if you cannot, you have to increase first the maximum pressure, then the PEEP, maximum pressure of the PEEP, because otherwise you are going to lose the driving pressure. So this is the maximum pressure, driving pressure of 15, 0 of PEEP. Then I increase PEEP 5. So I have to reach maximum pressure of 20. So driving pressure is constant, 15. So I go there up to the minimum pressure. You remember critical open pressure more than 25. You have to reach 30 of maximum pressure and 15 of PEEP. Even in preterm babies, even in neonate, even in small children, it's totally safety. I've dedicated all my life to know what are the barotrauma pressure and what are the safety range for these maneuvers. I dedicate all my life to safety ways to perform recruit maneuvers in all sites. As far as I know, I'm the only one who had published in 4 different papers what are the barotrauma pressure. That is beyond 65. And sometimes reaches 70, depends the way you get. So this is for children, the red one, and for adults is the light blue. So in children, in adults, you have to choose between 15 or 20 of PEEP. It depends of the obesity of the patient and the maximum pressure. But, you know, my approach is common sense approach. I'm not totally agree with Amato. I'm very sorry about that, but because Amato approach is more pressure, and then you have a trial study telling you that you have more barotrauma. So whenever you go for pressure beyond 60, 0, 6, 0, then you are in the deadline, in the red line for pneumothorax. So please don't go for that. So generally speaking, children 30, 15 totally safe, half of the pressure to create damage, and in adults 40-20. Obviously, there are some patients, like extremely obese patient, distress syndrome, laparoscopic procedures under the pneumola, under the increase of the abdominal pressure. Then you have to reach a little more, 45-50. But I highly recommend only to reach this pressure for the ones who are totally, perfectly well trained, and for them is recruitment maneuvers is like intubate a patient. I don't recommend for your first cases to go this pressure. Whenever we have reopened the lungs, we start to reduce the pressure. And as you can see here, the first thing we do is to reduce driving pressure up to 10, and then I start to reduce PEEP until we found the point with highest dynamic compliance. And as you can see here, when we reduce the pressure, compliance is going up, 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 until a certain moment that you reduce pressure, so the lungs recollapse. When the lungs go for recollapse, it is the first step that reduce in dynamic compliance. Please, another very bad, I mean, I heard a very important guides for even the ones who published randomized clinical trial against recruitment maneuvers. They explain recruitment maneuvers. Okay, if the lance is here, the compliance goes down. The only thing you have to do, increase a PEEP of 2. If the lance are recollapsed, you have to reopen it. And how do you reopen it? With another recruitment maneuver. And whenever you reopen it with the same amount that you choose in the first open up cycle, then you go directly for the step before. And then when everything is fixed, then is when we reduce the tidal volume as minimum to get the normal end tidal CO2 to get the lung protected ventilation. So here we have a video that is going to show to us how to do it automatically. Nowadays, in all anesthesia machine, we are very lucky because we have all this software you ask for them. So this is the pressure control ventilation with a constant driving pressure. So you here set the number of breath in every step. We recommend in the upper parts only 3 breaths in each step, and in the maximum open area 10 breaths is not needed more. And then you can go down. I recommend to use this software to really reopen the lungs and stay in the upper part. And when you have to go down, you can do it manually to get more steps. But remember, the first thing you have to do, reduce driving pressure up to 10, and then you start to reduce step by step the PEEP. So nowadays, it's, I mean, if you are very lucky to have this software, I mean, I can tell you, all the machines have it. So you only, whenever you are going to buy a new machine, ask them to put it, because really don't increase the price really. And even can be a upgrade. So what is the good thing of automatic recruitment maneuver? That you don't make mistakes. Why? Because you set the amount before start. You can check it before touching anything, and then the only thing you have to do is to push the start. You always have a button to stop it, just in case you have some kind of hemodynamic repercussion. And the second advantage about automatic recruitment maneuvers is like you're doing faster. You're doing faster because always manually is slower than automatically. Okay, so let's continue with the slides. So I think so far we can really cover the situation of how to do it, how not to do it, and what are the pressure to use in recruit maneuvers. So finally, the only thing we are going to go through, and with this we are going to finish, is like what are the best indications and the best, and the not good indication and the contraindication. And the only thing we have to do for that is quite simple. Recruit maneuvers is like any other thing in medicine. Can you tell me a single drug or a single ventilatory mode that you can use for all patients all around the world? No. So obviously, if you use recruit maneuver for patients with bad indications or for contraindication, what is going to happen? Bad results. But common sense and lung physiology. So this is my recipe for recruit maneuvers manually. You increase a little respiratory rate to make things faster and to clean a little more of CO2. In my approach for anesthesia, I never change eye relation because it's not needed. You are not going to go for auto PEEP or trapping. In COPD patient or in distress syndrome is different. pressure, maximum pressure to reach to reopen the lungs. Adults 40, 40, 40, 40 as minimum pressure. If you are not going to go for 40, 40, if I didn't convince you to go for this, don't do it. A pity. Your patient is not going to benefit from this skin, but try to give for 20, 25. You are not going to do any, and this is one of other clinical randomized trial, one from a very big guy like Gattinori, that they keep people of 10 in distress syndrome during the recruit maneuver. Obviously, open, close situation. If you don't follow, this pressure and these maneuvers, if you are not going to do it well, it's better not to do it. Common sense. So children, minimum 30, no less than that, and PEEP adults 20, children 15. VO2 is not needed to change in anesthesia if the patient is not saturated. Common sense. Why am I to recommend people 5? Because it's distress syndrome. So probably you're going to have overdistension areas and patient is in worse sound relation. So probably you're going to have the saturation. So if the patient is desaturated before the recruit maneuver because you allowed them to have a huge amount of collapse, then you have to go for VO2. But no, otherwise it's not needed. So PEEP at the end, in most cases, it depends of the procedures, but you can say, that in anesthesia can change from 3 in neonates operated babies up to 16 in laparoscopic procedure of a patient. So it cannot be give general rules. I'm very sorry. I would like to tell you, but it will be in truth. It will be aligned. So yes, I will go faster in this area, but just to show you that I've been dedicated all my life in the safety area about what is the safety area in recruit maneuvers. This was one of my first research performed in neonates to show the hemodynamic repercussion and the respiratory repercussion. About hemodynamic repercussion, we all know that during the moment, the 10 breath that you are in the high pressure moment, obviously you have a repercussion in pulmonary resistance. So you increase arterial pulmonary resistance. So right ventricular function is going to be, have more obstruction. So obviously during 10 breath period, so 20 seconds, there is a transit reduction in cardiac output. But after 10 breath, you are going to recover the cardiac output at the mean arterial pressure always. And between you and me is giving you, even from my side now, is really something is going to give you a very important information. I'll give you only two examples. Imagine intensive care area, a distress syndrome with a very fibrotic lung, and you have a lot of fluid, like all the patients are in intensive care, over fluid. You perform the recruit maneuver, and nothing happened in hemodynamics. Nothing happened at all. Do you think this is a good thing? This is a good information? I'm very sorry. It's the worst thing you can find. If you don't have any kind of hemodynamic repercussion, be careful. What it's telling to you? Two things. Fibrotic lungs, this one side, and they don't allow the pressure from the alveoli to transmit to the capillary. And the other side is like a cardiac function. It's telling you that the cardiac output is not preload dependent. Because if you stop the preload of the left side because you are stopping the right ventricle, it means like and don't have any change in cardiac output, it means like this heart function is very low, and you cannot improve the right function through preload. So you cannot give more fluid. So see how important even recruit maneuver is giving you information, clinical relevant information for hemodynamics. And just the opposite, you have a healthy lung after induction of anesthesia, 8 hours without liquids, and then you have, there's a reduction in blood pressure. What does this mean? That you need fluids to improve the blood pressure, cardiac output for this patient. And finally, this is what one of my latest research. It was doing not with isolated lines, it was doing with real thorax, it was real neonates, I mean piglets, obviously. And as you can see here, even for the ones who manage children, say, Javier, I mean, children is too dangerous. I did it many times. And I before doing in human beings, I did it with animals, and in human beings, and in everyone. And as you can see here, children have a very nice sign for you. Just in case, imagine the children have congenital cardiac defect, the cardiac output is not very well, the patient is dehydrated, whatever. The first thing you are going to see before the pneumothorax is bradycardia. So children even with low pressure around 50, around this area, between 40 and 50, that's why I don't recommend to go for that. Under 30, nothing happened, never, ever. So the first thing you're going to see is small bradycardia. So then obviously you have to reduce the pressure inside of the thorax. Pneumothorax in real life don't start less than 70. That's why I recommend don't go for 60. I mean, even in adults. So children, only 30, so it's much safer, 30, and 40 in adults is very safety area. So that's why we are very proud, because it was the respiratory care dedicated, or the editorial for our paper. And this is as a final message, good indication and contraindication. What are the best indication? In distress syndrome, only the first stage, the early stage, the first 2-3 days. That's why I highly recommend, even in COVID, I mean, recruit it when you intubate the patient, stabilize the lungs, and then don't recruit it more. So, and then better, the most important indication, anesthesia. Anesthesia atelectasis are totally reversible. Why? Because the patient don't come with it. So distress syndrome is different. Distress syndrome is not pure atelectasis. It's a syndrome with much more things. But anesthesia, remember, the major problem, respiratory problem, is atelectasis. Remember that between 6 years and 26 years, healthy people usually is not needed, because they're so stable that it's very impossible to create atelectasis. Bad results. So I don't recommend to start the recruitment maneuvers in this type of patient. If you have hemodynamic instability, you cannot use it. First, stabilize the patient. So check the blood. It's not needed non-invasive ventilation. Check the blood pressure every time you are going to perform a recruit maneuver. More than 11, 3 numbers. No, the patient, if the patient is already hypotensive, don't do it. So improve the hemodynamic, check hemodynamics. COPD patient, if it's more obstructive, you are going to see benefit. If it's more emphysematosus, never ever. Pure contraindication. Unilateral pneumonia, as we said, later stage of distress. And this is major contraindication in my point of view, that people usually don't talk about this. If you have severe intracranial hypertension with no monitor of the pressure, don't recruit the lungs. You are going to transmit some pressure. Trauma brain damage, trauma open pressure, emphysematosus patient, never ever use recruit maneuver. Pneumothorax without chest tube, bronchospasm or pulmonary bulla. So, finally, we are going for the conclusion or take-home message. Recruit maneuvers followed by PEEP should be instituted after induction of general anesthesia. Use of RVR recruit maneuvers may reduce postoperatory pulmonary complication. Like any other technique in medicine, you have to know how to do it, when to do it, and good indication and bad indication. And this is like my visual message for all of you. Intraoperative lung protective ventilation is not the same. From physiology, the concept is the same, but the way you do it is not the same, the intraoperative lung protective ventilation compared with intensive care. So why do I put this stool or this 3-leg chair? Because I want you to fix this concept. You can make a chair with the minimum amount, it should be 3 legs, or with 100 legs. As more leg, more stable. The same with lung protection. You have to apply at minimum three concepts, but at the same time, because if you remove only one of them, it doesn't matter which one, the chair is going to fall down. This is the concept I want you to transmit to you. So, and this is the reason that many clinical trials about this concept is not giving the right answer. You have to apply these 3 things at the same time to avoid postoperatory pulmonary complications. If you go for recruit maneuvers but without PEEP and without reduction driving pressure at the end, forget it. You are not going to see anything. That's what's happening in many papers. If you are going to go for recruit maneuvers but don't, just the opposite, sorry, use PEEP and no recruit maneuvers, you are not going to see anything. So the concept about protective ventilation is first, open the lungs. For that, the only secure maneuver is recruit maneuvers. Whenever you have reopened the lungs, then I set the minimum PEEP in an individualized way to keep the lungs open. And finally, because now you will see that with much less tidal volume and with less driving pressure, you are going to clean a lot of CO2, so you are going to need much less tidal volume that you are used to use. Then, when everything is fixed, open it, then you have to reduce tidal volume until you obtain the minimum end tidal CO2 required for these patients, something between 40 and better 45. Thank you so much. I'm here to answer all your questions. Thank you, everybody.
Thank you very much, Professor Garcia. So we have the first question already. Is there a role for lung recruitment during one lung ventilation?
Yeah, definitely. One lung ventilation is very important. You know, now is one of the areas that all this concept is spread and is applied. But at the beginning, for me, it was really strange that there was not many papers on that. Now you have a lot of them. One lung ventilation is crucial. It's crucial to use all this concept. And the way to recruit it is exactly the same. I'm going to tell you my practice. In thoracic surgery, before I intubate the patient, I fever bronchoscope, everything is fixed. So I usually reopen the lungs and just to know what is the PEEP that this lung is going to need. A recruit maneuver, when you are used to that, even manually, without the software, it takes you 1 minute, 1 minute and a half, no more than 2 minutes. So then I find out what is the PEEP that this lungs needs. So then I put in position and I clamp the lungs in the upper lung, not the one they are going to be operated on. So of course, one recommendation, when you are going to change from one lung to another, I definitely ventilate the patient under pressure control. Why? Not to create any high tidal volume every time you change the tube. The story is like sometimes the surgeon, open, close, open, close, open, close. If you are ventilating under pressure control, it doesn't matter. You don't have to change anything because what is going to change is the tidal volume, but you are not going to create damage. On the other side, I'm not saying to ventilate all the time in pressure control. Whenever everything is recruited and fixed, I change to volume control just to have all the tidal volume very, very well controlled. So whenever the patient is on position, I clamp the upper one. It's very important that the down part, the down lung, must be fully recruited. So in this case, yes or yes or yes. This in this moment is crucial to have a new recruit maneuver. Why? Because probably the PEEP that this lung need now in this position with all the weight of the thorax have changed. So probably the PEEP that the patient need in supine is not the same that is going to need when you are ventilate only one lung. So I recruit the lungs exactly the same amount. I never go for more than 40. That probably is not enough, I can tell you. But you know that patients go for thoracic surgery, lungs usually are not perfectly well situation. And of course, if it's emphysematosus patient, you cannot go for this. So I recruit the lungs in position and then I put the PEEP to stabilize that. You will see how the saturation that usually have under thoracic surgery is going to be much not so less situation. And finally, when everything is fixed and you are again in two lung ventilation, I highly recommend to do it when the patient is in supine. I fully reopen it again, set the PEEP, and this minute is going to help you that then you can extubate the patient 10-15 minutes later and everything will be perfect without atelectasis. Okay.
Thank you, Prof. Garcia. We have another question here. Is PEEP higher for obese patients?
Yeah, definitely yes. Definitely yes. I can say yes for sure, but I cannot tell you the numbers. I'm very sorry. This is not magic. Remember the paper I showed to you? I highly recommend you read it, because one thing that really impressed to me was that, for example, under laparoscopic, that even laparoscopic abdominal surgery is even worse, the PEEP was between 12 and 16. And you cannot say, no, set 12 for everybody. No, no, no. Because every time, the story about PEEP is, every time that you use a PEEP lower than you need it, you have problems, because you're going to have atelectasis and cyclic overdistension and atelectrauma. And whenever you use a PEEP higher than the minimum is needed, you are going to have, obviously, more hemodynamic repercussion. So, yes or yes or yes, you have to be trained in this new way of approach, how to reopen the lungs, how to individualize PEEP.
We have an interesting question, Prof. Garcia. Based on your observation, is intraoperative lung recruitment commonly practiced in Europe or in Spain?
Thank you so much for this question. We are, yeah, definitely. We already have published with COVID pandemic that you know that Spain, we are hitting too much. We are suffering too much. Not due to I mean, definitely we are going to be the country with more experience, and we can tell you a lot of things about this. That would be very nice if we could have the opportunity to have a specific webinar for protecting the lungs. And we already have finished my national congress here in Spain with 300 people, and we've been dedicated one day for COVID Day, and a lot of new things. Definitely, I can tell you yes. We published from all the intensive care units carried on by anesthesiologists, by Spanish anesthesiologists. 82% of the patient was recruited. And this is not the figures. If you go for LandSafe is one of the most spread, epidemiological research for intensive care all over the world. And they say, recognize that recruitment maneuver, they don't use it more than, I remember it was 14%. So, definitely it depends of the way you present this. It's not only my course. In Spain, we are very lucky because there was a course that now the doctor is retired. It's called Dr. Javier Belda, very well known in Spain and in Europe. Many places they run a course for the last 24 years, and he's retired. So, and now we are the ones who keep going with Bentimec. It's our national congress that we repeat every year, and now we did the 18th edition. So when you present the data in this way with isolated lines and people see it and understand it, probably the first time people is very anxious because it's totally different than we've been taught. But whenever you present the data in this way, people start to change the practice. I always say that courses must be done to change practice, not to have more information that finally is not going to change your practice. I've been traveling in 53 countries all over the world. So I can tell you, giving a speech and doing courses, and I can tell you that I have a wide view of the mechanical ventilation in both sides, in intensive care, in anesthesia. By the way, in both sides there are problems, not only in anesthesia. And the story is like, the problem is like, if you try to change your practice through papers, it's very difficult because it's not clear the message, and it's very confusing. So things can be changed, but things to be changed have to present the data in a different way, simple and visual.
Thank you, Prof. Garcia. There is a question related to that. Is recruitment maneuver always done every time we do general anesthesia?
Very good question. Remember, and this has been studied through Professor Gedestierna, that dedicated all his life to this concept. I learned, he's one of my mentors. I learned everything through him. He did a research with CT scan. In those days, it was allowed, but the data is there. That from 6 years to 25 years, so let's say 25, 30 years, the lungs are so stable that even under general anesthesia, you cannot create collapse. So probably this group of healthy people under general anesthesia, you don't need to do anything. Directly, I highly recommend, this is the exception. This is the exception that all what been talked before or we've been talking about. That is to set, I always recommend a small amount of paper, less than 5 even, only to prevent any compressive atelectasis during abdominal surgeries mainly, but you don't have to recruit them. Besides, remember all the contraindications. Pure contraindication, emphysematosus patient, intracranial pressure, emphysema, bulla, pneumothorax. Obviously, you cannot recruit it. Then, what can we do? Prevent atelectasis is the only thing you can do. That is, you can, even in emphysematosus patient, during the induction, you can put a mask for non-invasive ventilation, a small amount of 4 or 5 of PEEP, pressure support of 8, 9. So if you pressurize the patient, you seat the patient. Instead to be laid down like in supine, you can seat the patient during the induction. And then you don't recruit the lungs and then go for a small amount of PEEP. Then you can prevent to create more atelectasis. And the patient will recover after anesthesia to apply non-invasive ventilation because this patient can be managed in this way and because recruitment maneuvers are totally contraindicated. So beyond that patient who is contraindicated recruitment maneuvers and beyond the patient that don't need it, for the rest, I highly recommend to go routinely, as many other clinicians do.
Thank you, Dr. Garcia. I will be combining 2 questions next regarding the safety of recruitment maneuver. So one, is it safe to use recruitment maneuver in patients with poor RV function? And then next question is it safe in laparoscopic surgery?
Yeah, I will start with the laparoscopic surgery. Laparoscopic surgery I've been studying a lot. In this situation, it's crucial to recruit the lungs between induction of anesthesia and before pneumoperitoneus. Why? Because reopen the lungs whenever you increase the abdominal pressure, it's going to be much more complicated. You are going to reach much higher pressure, and you are not, even if I told you, I can show you a lot of things because the transpulmonary pressure is going to be the same, you are not going to feel confident. So, and besides, if the lungs are fully opened before the pneumoperitoneus, they are going to go for less collapse. So, definitely in laparoscopic surgery, after intubation of the patient, recruited, pressure control, it depends if it's obese patient or not, 40 if it's normal patient, 45 if it's obese patient, all these pressure are very safe. You recruited, set the PEEP. After pneumoperitoneus, and this is a very important question and difficult to answer. After the pneumoperitoneus, you will see how the dynamic compliance going down. But it can be 2 options, and you don't know if you don't have electroimpedance tomography. It can be recollapse, or it can be only because someone is pushing the thorax. Whenever if you want, push a patient the thorax, nothing is going to happen, and you will see how the dynamic compliance is going down. Why? Because dynamic compliance is a global measure of the elasticity of the thorax and lungs at the same time. So this is a very important question. After the pneumoperitoneus, I will see how the dynamic compliance is going down. Do I have to repeat a second maneuver? In most of the cases, yes. How can I know that? Simple. This is another thing you must be training. There's a lot of, I am very sorry, a lot of new things for only one webinar. Is to be trained how to calculate SAFI, saturation VO2 relation. There are curves that you can download. It's called ISO-SANT SAFI curves. That if you can get, you go down in VO2 and then in VO2 starting from 25, and then you increase in points of 10, and you put in the curve, in this curve, the saturation. So in 3-4 minutes, because this takes a little more time, you are going to see if the SANT have increased or not. If the shunt have increased more than 10, means that this patient have recollapsed. So then it's telling you the simple yes or yes or yes. You have to recruit it again with a little more pressure, 45.
What about in patients with poor RV function?
Yeah, okay. If the patient have respiratory problems, you have to know what type of respiratory problem have. Whenever, that's what we say in COPD patients, if you have some kind of emphysematosus areas, then I'm very sorry, you cannot apply recruitment maneuvers, never ever. The problem about emphysematosus patient, even if they have small areas, only small areas, is like this is like what I call chewing gun lung. So everything goes there. So if you increase pressure, you are going to overdistend this area and not gain anything in the rest. So you must know the respiratory function, and you have to know what are the especially this kind of patient for thoracic surgery usually have a better pre-assessed test, like respiratory function test, that is going to tell you that it's pure obstructive or not. So really, I am very worried about the safety of recruit maneuvers. If you perform recruit maneuvers routinely with the pressure I told you, in the patient I told you, the way I told you, you are not going to find out a single problem, never. So please don't go for difficult patients. Start with normal patient. Start with normal healthy patient. Start with your routine patient. And whenever you are very used to that, probably you can apply sometimes in some special cases. For example, lung transplant. You know, before I moved position to Puerta, Hierro, that is the hospital reference for lung transplant in Madrid, I've never had the opportunity to perform any lung transplant. So I try to recruit in some of them. I can tell you in some of them, this is the worst thing you can do. So if you have respiratory problems, you must know very well what type of respiratory problems you have before using recruit maneuvers. Start with normal, simple cases, and whenever you are very used to do it, then you can apply in more limited situations.
Thank you, Professor Garcia. We have many, many more questions, but I think we will just do one more because we are already way over time. Is recruitment maneuver safe for patients with poor right ventricular function?
Okay, that's the hemodynamic part. I love this question because it's very, very interesting. There are several papers, but there are one from Gerardo Tussman that I love it, that they perform recruit maneuvers in cardiovascular surgery. And what they did was to, with an echo, transesophageal echo, they measure all the right ventricular function before the surgery, after the recruit maneuver, after winning the bypass, and 1 hour, only 1 hour, 1 hour later in the intensive care unit. So they show to us something incredible. Even the ones who have better outcomes in the right ventricular function 1 hour later in intensive care was the one who's been recruited and set it individually PEEP. And the explanation is very simple. Okay, what is the worst thing for the right ventricular function? The pulmonary resistance. If you have pulmonary hypertension, so right ventricular function can overcome load, so volume, without not that big deal, but really to overcome high resistance, high pulmonary pressure, for them is really bad. If you have a huge amount of atelectasis, what is the reflex that is going to institute 15 minutes later? Pulmonary vasoconstriction. Pulmonary vasoconstriction reflex, what they do is to close all the pulmonary capillary 15 minutes later that you have atelectasis, because to preserve oxygenation. I always ask to everybody, say, pulmonary vasoconstriction, hypoxic vasoconstriction is good or is bad? It doesn't matter what you answer. I'm going to tell you you are wrong, because pulmonary vasoconstriction hypoxic pulmonary vasoconstriction. It's good for the patient to not have the saturation when you have a pneumonia. So it's a surviving reflex. But it's very bad for who? For right ventricular function, because you create a huge amount of increased pulmonary resistance. So obviously during the recruitment maneuver itself, I'm talking about 10 breaths. 10 breaths mean 25 or 20 seconds. During 20 seconds, of course, you are going to, and this is for sure, it's totally measured. I did it many times. It's published all around the world. During the period of overdistension in the upper part, you have 20 seconds of increase in pulmonary resistance. But when you reduce, you remove all the pulmonary hypoxic pulmonary vasoconstriction. So there is a huge reduction in pulmonary resistance. So then the right ventricular function always improve. So obviously, if you are, for example, imagining cardiac vascular surgery, very bad right ventricular function. So always you have to use amines. I mean, norepinephrine, adrenaline, dobutamine, whatever. So in these specific cases, what I did is I always increase a little amines to have some support during the maneuver. And then I can tell you, and you will see, that's why in this paper show this huge amount. Even there are another Lancet very recently, 1 year ago, in cardiovascular surgery, that recruitment maneuver really improve the function, and you reduce the doses of amines in the postoperatory period. You will see how the right ventricular function is going to improve. So you have to do it, but during the 20-second maneuver, you must be careful about the hemodynamic parameters.
Thank you very much, Professor Garcia. So I will just be sending you over all the other questions that are still here, or else I think we will finish at midnight.
It's my pleasure. I will send you an audio because for me it's faster with all the answer of the question, and you can link them or send to the
Thank you very much, Professor Garcia. So thank you so much for imparting with us your knowledge and experience on lung protective ventilation in the operating room. To everyone on this webinar, please do not forget to answer the poll questions and register for our next webinar session, Implementing Standardized Response to Deterioration Using the National Early Warning Score, on October 5, 2020. Thank you very much and have a good evening ahead.
Thank you, G, for making this possible. Thank you to all the participants for your time. I hope you all the best in this period.
Bye-bye.
Bye-bye.